Thank you, Uma. Thank you, Russ. Good afternoon, everyone. So in tackling this topic of immunomodulators in IBD, I'm reminded of some wise advice that I got from my mentor, Steph Targan, when I first started seeing patients with IBD. And that is when you have a complicated patient with a long, complicated history, take it from the beginning and go chronologically. And that's kind of how I want to frame this approach and discussion of a discussion of immunomodulators in IBD. And that cartoon on the right says, "Doctor, I think my life is out of chronological order." And then the doctor says, "Good morning, how can I help you?" So that's not the approach we want to take. This is actually eloquently summarized by Steve Hanauer in a recent editorial going through the history of azathioprine 6-MP for Crohn's disease. And really, starting way back in the 70s and even earlier, studies suggesting maybe it worked, maybe it didn't work. The National Crohn's Cooperative Study showed azathioprine not effective for Crohn's, but it was a low dose. And then we had a study by Dan Present in the New England Journal showing it did work for induction maintenance in Crohn's disease. Then there were several studies with some contradictory data. And then we have the Markowitz pediatric study, which I'll show you, which was a landmark study demonstrating the effectiveness of induction and maintenance. Go early and go in combination with steroids, which is kind of what we have tended to do. And then things shifted a little bit. We started appreciating some of the risks associated with the thiopurines, particularly lymphoma, hepatosplenic T-cell lymphoma. Then we had some Cochrane analyses, going back and taking a look at details of studies and combining them, and the message maybe was that azathioprine is effective for maintenance therapy and that we need higher doses, but not for induction therapy. Looking at the pivotal trials of the anti-TNF studies, each trial had patients coming in on immunomodulators didn't show that combination was superior to individuals that weren't on combination. And then we had the definitive SONIC study, which Doug alluded to, and I'll talk about as well, that actually showed that azathioprine was clearly inferior to infliximab and the combination of azathioprine and infliximab. And then in the last few years, we've also seen a slew of studies trying to really tackle this question to understand what is the role of immunomodulators in the treatment of Crohn's and ulcerative colitis. So we've had several now Cochrane reviews telling us pretty clearly that azathioprine 6-MP as monotherapy do not seem to be effective for induction therapy. We've had the RAPID study and the Aztec study, and Doug showed us the RAPID study, looking at, these are randomized clinical trials, and I'll show you that data showing that azathioprine is not effective for early induction and then maintenance therapy for Crohn's disease. We've also had some now data on withdrawal studies. So when you've got patients on combination therapy and then withdraw the biologic drug and maintain on thiopurines, there is a very significant relapse rate. But perhaps if we can dig even deeper into some of these studies, you might glean some insights into helping us understand the proper positioning of these thiopurine medications in inflammatory bowel disease. So I alluded to this study. On the right is the Markowitz study, which was done in children, and the Candy Wright study on the left. These were early trials basically showing us and demonstrating that it would look like that in early Crohn's disease, certainly in children, there was a significant advantage to those children started on azathioprine monotherapy compared to those that weren't. And then in the adult study, that was a similar correlation in adults that were randomized then to receiving steroids, corticosteroids alone or corticosteroids with thiopurines and then continued and followed out for 15 months, that those that were continued on the thiopurine did much better than those that weren't. Again, positioning where this drug was back in the late 2000s. And then again, these meta-analyses were done, and there have been a series of them. In patients with Crohn's disease, basically a summary of these summary studies is basically going through the literature and showing that thiopurines by themselves do not appear to be effective for induction therapy. And that when that's, again, as monotherapy, when they're given with steroids or when they're given with biologics, that's a different story. But as monotherapy, thiopurines are not effective for induction. Thiopurines are, however, effective for maintenance of remission and for steroid-sparing options, and this is true in Crohn's and in ulcerative colitis. Thiopurines are effective for prevention of post-op recurrence. I'm not going to really talk about this a great deal, but there are a couple of studies, and there's really limited data here suggesting that certainly thiopurines may be better than placebo. However, the caveat with Crohn's disease, its use is limited by adverse effects. And similarly, in ulcerative colitis, Cochrane meta-analysis, similar conclusion, effective for maintenance when 5 ASAs fail and when patients have been exposed to multiple courses of steroids. And again, the caveat, its use is limited by adverse effects. These are the two relatively recent randomized trials that were done in Europe. The RAPID study on the left in France that Dr. Wolf showed us, demonstrating that patients treated with early azathioprine therapy right off the bat, as opposed to those that were given conventional management, and then following those patients out to see who stayed in remission, demonstrates that there was really no difference between those two groups. Similarly, in the Aztec study, which was done in Spain, 131 naive patients were randomized, and by the way, the study was terminated early because of lack of effect. Again, these are patients that were diagnosed with Crohn's disease within 8 weeks, and then put on this study, assigned to receive azathioprine or placebo, and again, looking out into the proportion of patients that maintained in remission, that basically there was no significant difference between the two. There are lots of different ways that we can define remission, and if you dig into the studies, there's quite a bit of heterogeneity in there, but one very hard outcome to look at is the need for surgery. And actually looking at meta-analyses of studies does seem to favor thiopurines with respect to avoidance of surgery in Crohn's disease. When we look at some studies now that look at the specific dosing of thiopurines, and I think this is a really important concept that unfortunately many studies fail to control for, is really looking at the dose that's being used as measured by the metabolites. And there have been a couple of meta-analyses that have looked at the association of 6-thioguanine nucleotide levels and IBD disease activity, both Crohn's and UC, although predominantly done in Crohn's disease, demonstrating that patients who have adequate levels or high levels of 6-thioguanine are the ones that do the best when treated with thiopurines. And this is actually an updated meta-analysis showing the same thing. Now, there's quite a bit of heterogeneity in the types of assays that are used for these studies, but even when controlled for the type of assay, there seems to be a very significant difference when patients who are dosed with thiopurines achieve therapeutic levels of their 6-thioguanine that is associated with clinical remission. And again, I want to highlight the point that many of the studies that we've discussed don't actually optimize for 6-thioguanine levels. Patients are assigned a fixed dose, a fixed weight-based dose. And there are actually several other points that are raised as far as interpretation of these two trials that I've mentioned. There's a unique endpoint that has been used in the Jataid study, and also the use of the CDAI and the criteria for how we're actually defining response and remission, knowing that those fall short of how we think the ultimate best way is to define remission. Dr. Wolf mentioned the SONIC trial, and I think there's a lot of insight that we can gain about the proper positioning of thiopurines, both as monotherapy and combination therapy from the SONIC trial. So let's first talk about azathioprine as monotherapy. These are the high-level results of the primary endpoint, which was corticosteroid-free remission at week 26. Again, these are 500 patients that were assigned randomly to receive azathioprine monotherapy, infliximab monotherapy, or the combination of the two. And these are patients who are naive to both of these drugs. And what you can see here, you could flip it around and say, well, yes, infliximab plus azathioprine seem to do the best, but actually flip it around and say azathioprine monotherapy did the worst. And that clearly seemed to clearly show that azathioprine monotherapy was not as effective a treatment strategy as either infliximab or the combination of the two. But if we dig a little deeper into the SONIC trial, I think there's several questions that we can raise. So we know as far as the dosing of azathioprine during this trial was a fixed dose. And in addition to that, patients who had abnormal TPMT levels, thiopurine methyltransferase levels, suggesting of abnormal metabolism of azathioprine, were excluded from the study. They had to have normal TPMT activity. In addition, those patients were all receiving the same dose of a weight-based dose of 2.5 milligrams per kilogram, but there were no measurements of 6-TG concentrations, which we've discussed has been associated with differences in response. There's a provocative study that was published that looked back at the actual SONIC data using a surrogate for the 6-TG concentrations. We know that when patients receive thiopurines, their MCV, the mean cell volume, the mean corpuscular volume of the red cells actually increases. So some people actually dose azathioprine to changes in MCV. And delta MCV, a change in that MCV of more than 7 has been associated with levels of 6-thioguanine. And so this was a post hoc analysis going back looking at the sonic data saying, well, maybe we don't have the 6-TG level in this study, it wasn't actually measured, but what if we go back and estimate the effects of therapeutic, quote unquote, levels of azathioprine using this surrogate marker of delta MCV, of a change in MCV. And if we do that, as this study showed, we select out those patients that were treated with azathioprine as monotherapy and look at those only who had a delta MCV of greater than 7, what we actually see is that there's a very significant response rate of corticosteroid-free remission in those individuals, again, who had quote-unquote therapeutic levels as determined by a delta MCV of greater than 7, which again is a surrogate marker of having therapeutic levels of azathioprine. So again, a provocative study. What do we take from this? Raises again the question of the dosing of thiopurines and its role in the use of monotherapy. Still, I think the evidence overall suggests, and these are several guidelines that have been published in the last few years, AGA guideline on the use of thiopurines, methotrexate, and anti-TNF therapy for induction and maintenance of remission in Crohn's disease. We suggest against using monotherapy of thiopurines to induce remission in patients with moderately severe Crohn's disease. And when it comes to maintenance, we recommend using thiopurines over no immunomodulator therapy to maintain a corticosteroid-induced remission in patients with Crohn's disease, again, suggesting that there's some benefit for maintenance, but no benefit to induction therapy. I want to also point out Crohn's disease clinical decision tool. There have been these clinical decision tools that have been published in gastroenterology in the last few years for Crohn's and ulcerative colitis, and I'll touch on both of them. Not really a guideline, but a practical clinical decision tool as to how we should be thinking about utilizing therapy. And I would certainly encourage people to look at these decision tools because they're very practical. And what the Crohn's disease decision tool does is it kind of changes the way we think about how we classify our patients in order to determine which drug to give which patient at which time. Instead of kind of the classic definitions of patients and categorization as patients in mild, moderate, and severe disease, instead, what Dr. Sanborn and his colleagues in this Crohn's decision tool was kind of modify that. It's a different framework that we're thinking of. We're not thinking of the patient in front of us as mild, moderate, severe, but rather we're thinking of this patient in front of us as low risk for bad stuff happening, for future complications, or high risk for bad stuff happening and future complications, and utilizing that categorization and classification in order to guide us as far as therapeutic management. And so if we look at this clinical decision tool and looking at those low-risk patients, what's recommended in here, and specifically for the low-risk patients, for those who have ileal disease or proximal colonic disease, none to minimal systemic symptoms, the options would be to use budesonide, 9 milligrams per day with or without azathioprine, and a tapering course of prednisone with or without azathioprine, or for patients who have diffuse or left colonic disease, again, the tapering course of prednisone with or without azathioprine. So for these low-risk patients, this seems to be a positioning recommendation for where azathioprine as monotherapy should be. So again, monotherapy here as maintenance when a steroid-induced remission is successful, again, in these low-risk patients, these patients with Crohn's disease who are not at high risk for complications happening. And there's clarification in here of all the details as to what would actually classify a patient as high risk. Those would be individuals with deep ulcers, individuals with perianal disease, individuals diagnosed at a young age, active smokers. These are patients who are high risk, and those are individuals who we wouldn't necessarily consider this strategy, but rather the high-risk strategy, which does not involve the use of monotherapy of thiopurines as maintenance. The ulcerative colitis decision tool is shown here, and actually one of our speakers, Miguel Reguero, was the senior author on this. So the ulcerative colitis clinical decision tool also utilizes azathioprine, and here we're talking about patients who are high risk when it comes to ulcerative colitis. And so these are individuals who have had multiple courses of corticosteroid therapy, and so there's a few different options. And one of the options here would be to start corticosteroids with initiation of a thiopurine, so it's kind of combination therapy, if you will, of steroids plus azathioprine, and then maintaining that remission with thiopurine, and that is and would be an acceptable option in this population of ulcerative colitis patients. So that's really thinking about azathioprine as monotherapy. What about azathioprine as combination therapy? And this, again, is an important lesson that we've learned from the SONIC trial. Why is it that combination therapy seems to do better than monotherapy with infliximab? What is it about adding the thiopurine that makes the combination better? And so this is data from that trial, which suggests that a primary reason, maybe the only reason, or maybe one of the reasons why, is because of reduction of immunogenicity. And what you can see here in that green in the middle is that patients who were treated with infliximab and placebo had a significant rate of antibody formation, as opposed to those that were treated on the right with azathioprine plus infliximab with reduced antibodies. And in fact, this also correlated with improved and higher levels of the actual infliximab drug. So azathioprine addition to infliximab seems to lower the rate of antibodies and raise the level of the drug, which may account for why it's efficacious more so than the use of infliximab by itself. There may be other reasons, though, and there's speculation as to what those may be. So the question is combination therapy that we've learned about in the SONIC trial is really a definitive study, 500 patients, randomized 3 arms. Is that a lesson that will always, therefore, be relevant and applicable in all settings? And I think we don't have a lot of data to guide us for some of these nuanced details when it comes to the specific patient in front of us. There's many scenarios where we might consider the use of monotherapy versus combination therapy. The SONIC trial had patients who were naive to biologics and immunomodulators, but many of our patients are no longer naive, and they've been exposed. And how should we think about combination therapy in those patients versus those that are failing an immunomodulator, and then we decide to start combination therapy or monotherapy with a biologic? The post-op setting, it's not totally clear. What do we utilize in that setting, a monotherapy or combination therapy, which is better? What about after patients have been in deep remission, and then for how long before we consider or take away the biologic drug and leave somebody on monotherapy with a thiopurine? What about other anti-TNFs that weren't used in the SONIC trial? We have some data, but really not a whole lot of data to guide us with respect to other anti-TNFs and other biologics. Now we have 2 other biologic classes. How should we be thinking about combination therapy? And I think we really just need more data. Dosing of IM, as we've discussed, is also a very significant issue because we know that patients who are treated again with thiopurines and have therapeutic drug levels of the thiopurine seem to do better. Russ, you mentioned Bridge online tools in your early questions. This is another Bridge online tool that goes through some of these scenarios, over 220 scenarios of some of these different nuances, at least to see, and that's an online a tool that can use. There are actually several available to try to get at some of the details. If we can't have evidence for anything, at least what does an expert opinion determine? And then what this is here is another look at the SONIC trial, and I think that we have to also consider the safety issues. And so with this was a meta-analysis, I'm sorry, not of the SONIC trial, but of all the pivotal trials of the anti-TNF drugs, all 3 of them, infliximab, adalimumab, and certolizumab, looking at the patient-level data and monotherapy versus combination therapy in patients coming into the trial. So some came in while they were failing a thiopurine and started both, and some came in naive or not on a thiopurine and started just monotherapy. And one of the sub-analyses, looking at the supplementary tables, shows us that, at least for infliximab, there seemed to be a benefit to combination therapy over monotherapy, which we've known about. But also, when looking at safety, there were no safety signals to suggest that combination therapy was less safe than monotherapy. But not only that, in fact, when it came at least to infliximab, there seemed to be a benefit, a safety benefit to being on combination therapy with reduction in infusion reactions. So just to end off with a brief discussion about safety, certainly the safety that we think about in 2 main categories, infection and cancer risk. When it comes to serious infection risk, at least in the TREAT registry, did not seem to be a significant increased risk of infection, although clearly we do know that there is an increased risk of infection, hard to quantify, and the types of infections also hard to quantify specifically with respect to thiopurines, but does seem to be an increased risk of infection. And then when it comes to risk of lymphoma using azathioprine, does seem to be an a very small but real increased risk of lymphoma. And as we've learned, there are different kinds of lymphoma, and those different kinds of lymphoma may be associated with different likelihoods. For post-transplant-like non-Hodgkin's lymphoma, perhaps a rate of 1 to 1,000 patient years. Early post-mononucleosis lymphoma in individuals who are seroconverting their EBV status, maybe even rarer than that. And then hepatosplenic T-cell lymphoma, even more rare than that. This is my final safety slide. This is also to remind us that lymphoma is not the only cancer that has been associated with thiopurines, but also non-melanoma skin cancer. And what this study was that 20,000 patients followed in France prospectively, showing us that the risk of non-melanoma skin cancer increases in individuals exposed to thiopurines, not only who are on thiopurines today, but also who discontinued thiopurines. And so that risk also seems to go down, warranting certainly recommendations for screening for skin cancer in these individuals. So in summary, when we think about positioning of thiopurines in Crohn's disease, when we think about monotherapy, really they should be dosed appropriately in general. Thiopurines are considered generally safe with the caveat that they do have risks. Appropriate for uncomplicated, low-risk Crohn's disease. Appropriate for ulcerative colitis failing 5-ASAs, steroid sparing, but has risks. And the studies really that have been done that we quote did not show a benefit, however, with the caveat that they didn't optimize thiopurine dosing according to levels. When it comes to combination therapy, we do see evidence of more effective, that the combination is more effective than monotherapy, especially when patients are naive as in SONIC, that immunogenicity, prevention, and higher anti-TNF levels seems to be the mechanism, and in some cases may be safer than monotherapy, but we need to understand really what doses are we talking about, and perhaps we can get away with lower than therapeutic doses when using them in combination. Thank you very much.